My first remark is there one theory that can explain everything, that fits every case of cancer? I'm still wondering, because my feeling is that rather than having one theory, perhaps we have a threesome between a tumor, host, microbiota, or in other words, metabolism, genes, and immune response, or perhaps even more than a threesome. And my first question, after I would just have one remark, but my first question is, we have strong models of cancer due to mutations, genetic abnormalities, such as lung cancer. Lung cancer is increasing, is due to a powerful mutagen, which is tobacco, and there is a lot of epidemiological and biological data showing that genetic abnormalities are part of this lung carcinogenesis. We also have models of cancers due to the germline mutation. So how can we explain these facts? I agree that not all smokers and not all BRCA mutated women develop cancer, but how can we explain these facts with the theories of metabolism or immune response?
So Laurent, you want to
start?
Question. Laurent, start. You speak as a metabolic disease, not
okay,
genetics.
I'm going to give you a personal answer. We demonstrated that the toxic element in tobacco is carbon dioxide. Tar, we know that the tar level, which was supposed to be the main culprit, has gone down by 5 to 6 times in the past 20 or 30 years. CO2 has not changed. CO2 is a poison of the mitochondria. When you remove the CO2 from the smoke, the animals are fine. So probably you're dealing with another metabolic disease, which is caused by poisoning by carbonic gas. We are facing with a change of paradigm. This change of paradigm, which is now the mitochondria at the center, when it was a nucleus at the center, does not mean mutations do not exist. They do exist, but they drive the mitochondria and the metabolism differently. And to a certain extent, it's very difficult to change paradigm and to move to another era. And that's what we're discussing right now, with all the difficulties that we all know.
We need another conference to answer your question, but I will try in two sentences to make a point clear. So first of all, we all believe that cancer is a multi-step process, so we are not going to contest that all of that is true. But mainly you need, the first hit is a mutation, presumably, and the second hit is a disabled immune system to struggle against the mutation. So either the mutation is immunogenic and strong enough to elicit strong T cells, and the mutation will be recognized, if I can say so, by the T cells that would eliminate the very cancer cells, and we will never know that we had a cancer because we just eliminated it as soon as it was arising. Or we were disabled to recognize the cancer, or the cancer was just impossible to recognize because these mutations were just mutations that are not driver mutations or that were not immunogenic mutation. And in this case, we are blind and our immune system is useless. So after one mutation, you get other mutations and it's getting complex, and then the cancer grows out. And as a matter of fact, when it grows to a certain volume, it disseminates many metabolic immunosuppressors and many soluble factors that are dampening every kind of struggling system. So I think it's pretty easy, and everybody somehow recognize the power of what we call chemoprevention or prophylactic maneuvers. And so what we want is to make sure that we would like to control mutations, meaning we would like to reduce xenobiotics, we would like to purify our microenvironment from all these toxic environmental cues, but we also want our body to be strong enough to be able at least to have the immune tone and the microbiology-mediated immune tone strong enough to counterbalance any mutation that we would have contracted. So that's the point of this conference. How can we get to this cancer immune set point, which is that even if we get mutations, we are strong enough to see these mutations and to eliminate these mutated cells at the right time by nutrition, by yoga, by physical exercise, and that's, you know, that needs former clinical trials to be able to get to the point of linking these phenomena all together.
So I also would like to say something on this example of non-small cell lung cancer. So, of course, smoking is one of the major risk factors, and most cancers develop in smokers, although the rare lung cancers that they develop in non-smokers are actually worse. They have less mutations and are less recognizable for the immune system. And so when a cancer is diagnosed that is classified as a non-small cell lung cancer, it is usually staged. So it's stage 1. In this case, it's usually discovered by chance by radiography for other indications like tuberculosis or plastic surgery or something like that. It's can be stage 2, stage 3, stage 4, so ever more disseminated. And you can compare the importance of this staging, the classical histopathological staging with the new ways of classifying cancer by looking at the immune infiltrate and by looking at the features of the cancer cells that make them recognizable to the immune system. So you basically study the presence of CD8 positive cytotoxic T lymphocytes in the tumor. You study the frequency of regulatory T cells that are immunosuppressive. You study the frequency of dendritic cells that can activate the immune system. You study the capacity of the T cells, the tumor cells to express calreticulin, which is one of these adjuvant signals that activates the immune system. And you will actually discover in the end that these immune parameters are much more important than the classical staging, meaning that, for instance, I can just give you one example. A stage 1 lung cancer that is calreticulin negative and hence will never be seen by the immune system and is free from T cells and from dendritic cells. That stage 1 lung cancer that is very small will have a worse prognosis and will kill the patient more quickly than a stage 4 lung cancer that is immune infiltrated. So the immune classification supersedes in importance the T and M classifications. Just to say how important this parameter is, that has been until now widely neglected.
So do you think there is a way by epidemiologic view or WHO work to reconcile everything here? Because we have a lot of different view of cancer which have been exposed, very difficult to put them all together. So how can we work on this topic?
Well, I'm a cancer epidemiologist working on a large prospective cohort study where the data and the biological samples were collected long before, many years before diagnosis. And we look at the determinants of cancer development and the underlying mechanisms. And I'm intrigued by the parallels that we observe in much of the data presented today. We look at the opposite of calorie restriction, which is weight gain and obesity, and we see the same mechanisms. We look at the influence of diet and lifestyle on the gut barrier function and the breakdown of the gut barrier function and endotoxemia and bacterial translocation. We observe the very same findings. And it demonstrates that cancer development is a long-term process that begins with dietary, lifestyle determinants, and of course the underlying genetic basis. And these aspects go together hand in hand, and I don't think they can be separated. And we see these determinants beyond diagnosis into survival as well. And it would be of great interest if we can converge the field of epidemiology with the molecular aspects that you study.
Can I just, we have diverging or non-converging ideas. For some of us, cancer is simple, for others it's a complex disease, and probably the two are true. The very reason I think for this meeting is to keep on moving. Looking at, for instance, fasting and toxicity, you need 10, 15, 20 patients, something like that. Looking at the work we do, it's about 10 to 15 patients to have a proof to know if it's right or wrong. And time has a reason that should take place in an institution, and if possible, in France, because I'm French. And the time is ready, and it's now. If that does not go, it will be done outside without the security of science. I started with lipoic acid and hydroxycitrate. From what I know, true or not, from the feedback I got from the industrialist, it's about 10 to 20,000 people who take that. I do not know for a fact if it's effective or not. It's likely to be effective, but I do not know that. And that's the same for diet. I see a lot of people call me who have not eaten for 6 weeks. People say 6 weeks is necessary. Nobody knows why. It's out of the limbos. Trials are needed, and trials are needed now. That's what I wanted to say. I'm sorry.
Okay, that's what we are going to do. So we have a question here.
Yes, first of all, thanks a lot and congratulations for the amount and the quality of work that was presented this morning. And second, I would like to ask, as a pharmacist, don't you think that at the end it would not be important to standardize as well, to evaluate the microbiome and also all kind of immune cells that you have in your body before the treatment, during the treatment, and after your treatment of chemotherapy, immunotherapy, or whatever? And that at least that clinical assays are really important to address this issue in order that these standard dosage are done in hospitals in a correct manner, that you could really collect data that could be useful not only for your own patient but for the whole community. Because we are starting to see also that some people, in particular in France, that are starting to address some of their analysis to other countries, and also maybe they will start to private laboratories in France soon. And at the end, this data will maybe lost somehow, and this data could be important for your work and for the work of all of us and for patients.
Well, you are absolutely right. We need to standardize these methods, and this is going to be done presumably by biotech companies who have, the appropriate setting to develop this routine, this test routinely. I am pretty confident on the fact that the Ministry of Health and Education will support this type of studies.
I have a question here. First of all, I'd like to say how delighted I am that the discussion is actually entertaining an alternative view of what we're dealing with here. For more than 50 years, we have discussed nothing except the genetic basis of cancer, what the mutations are doing, how they're doing this, and all we've had now are more and more dead cancer patients. We have to recognize that. We are treating cancer patients with all kinds of new therapies, but they're still getting sick, all right? The immunotherapies are magnificent in the very few people that it actually works on. It's also financially unacceptable to have someone pay $400,000 for treatments, $100,000 for a treatment. This is called financial toxicity. This is totally unacceptable, all right? We're going to find out, in the end, there's dust to be settled. Dogma is strong. It's more powerful than most genes that you can possibly have. Your brain is convinced about something that may not be correct, all right? So, in the end, we have to do trials, I agree with everyone, and who emerges from the trials healthier and cancer-free and not broke, all right? That's going to be the determinant, how the people respond to the various trials set up based on the gene theory and based on the metabolic theory. Only then will we come to know which of these possibilities was the correct one.
So one or two last questions, and then we'll have to break. We'll have time this afternoon. So.
Maybe again a short comment how we can join the series together. Cancer as a genetic disease is the same as cancer as a metabolic disease, because what do genes do? Genes do nothing for themselves, except they code for proteins and peptides. And proteins and peptides build enzymes, build signaling molecules, build structural molecules, build immune molecules. And if there's a mutation in the gene which is based for the building of the functional protein, then we have a disturbance in either the immunology, if the immunology coding protein is disturbed, or in metabolism, or in the mitochondria, if the corresponding proteins are not built correct because of a mutation at a location in the coding gene which is of importance. So, for example, MYC is one of the most important genes, oncogenes, mutations for a lot of cancers, but MYC is a central protein we now know for metabolism. So this is not two theories, they are joined together. Genes are necessary for proteins, and proteins are necessary for metabolism.
So Laurent, you can agree that we have relation, both Laurent, we have relation between genes and metabolism, so it's not incompatible. So Laurent Zelek or Laurent Schwartz, can you agree that genes are important for metabolism too?
Okay, we agree that gene code for protein which are involved in the metabolism.
So we can at least make those two hypotheses together.
It's just a change of the hypothesis, that's all.
So Walter is going to give a last comment before the break.
No, I had a question for Guido and Laurence. After you do the bacterial transplant, you call it transplant, is there a long-lasting effect, or is there like a resistance acquisition? So how long does that last? I mean, did you look at 3 months later? Does it keep on going or not?
Yeah, it's a good point. So yes, there is a counter-regulation. If you push a bug too much, you will have an ecosystem which will react to the invader, if I can say so, and so you neutralize or you balance your ecosystem with another flora. So you shift the flora by just putting one bug overtly, and the way you shift the microflora might be beneficial or deleterious, but that's complicated to conclude at the moment. But you're right, of course, there is a feedback that aims at reestablishing some kind of equilibrium. So we need to look at that. But the point here, I think, to be on the safe side and to convince regulatory agencies is to sell the concept at the very moment where you inject your treatment, because the treatment is activating an immune system in the context of a good immune tone. So you just put the right bacteria to lower the threshold of the immune tone so that your treatment will start being efficient. And then you stop to avoid this feedback loop that we always get, either using immunomodulators. When you put interferon gamma, you get IL-10. When you put IL-12, you also get, counter cytokines. So in other words, it's better to have acute treatment rather than chronic treatment, because you never control, the constant exposure to an overdose of a bug, I think.
Great.
But this needs to be experimentally tested.
Yes, well, so we are now at the point to take a break for lunch. I want to first thank the speakers from this morning, especially the speakers on the panel. I think we've heard some extraordinary really good research. Maybe my editorial comment would be that we are now for the first time in a cancer institute at a cancer meeting beginning to speak about mechanisms that underlie healthy physiology perhaps as well, with immune cells, cytokines, pH, biochemistry. In a way, it's going back, not refuting medical school, but asking us to re-examine from the very beginning some of the things that we've learned and to not simply dive at the therapeutic side. And I also think that as we go forward for the rest of the day, to remember that as we move forward, the researchers need funding, that clinicians need community support, and that there really needs to be a globalism of thinking that involves systems biology as opposed to one person's idea or one lab's perspective. And what I think has been represented this morning is a variety of ideas and perspectives that we hope to unify in this conference as opposed to create different schools of thought. So with that, we will go to lunch, which will be right outside the room. We will return at 2:15, and we can continue our discussions more informally. Thank you.